Well, good afternoon or good morning, everyone, depending on where this broadcast finds you. It's nice to see some familiar names and a few familiar faces. If you have your camera on, wonderful. I'm going to let everybody there's still a few getting connected to audio, so let's give them a chance here before we get started. I want to just thank everyone for taking the time out of their schedules to be with us today, and looking forward to hearing from our guest speaker today regarding treatment planning as part of the clinical evaluation process. So looks like just about everyone is connected. So I think there's just a couple more that are, looks like Dave is still getting connected to audio. And I thought Heather was still connecting too. So, but maybe we'll get started and they can jump right in. We have disabled the waiting room. So if we have anybody arriving a little bit later, they should be able to join us without a problem. Again, I want to welcome everyone to another installment of our ESAS webinar series. Essential Substance Abuse Skills Training is the acronym for ESAS. If you've not been to one of our ESAS webinars, these are very popular amongst our viewers, and it's something that our center here has been running for many, many years. So I am going to ask that everyone remain muted. So if you're not muted, Jeff and I may mute you. I have Jeff Ledolter on, one of my colleagues from our center. Vicki, I've muted you. And I see if there's anyone else that's not muted, please do so, just to keep things a little bit easier so we can communicate better. Looks like everyone else is muted. So there may be an opportunity to unmute and ask some questions towards the end of the presentation. So again, my name is Steve Steiny. I am one of the managers here at the National American Indian Alaska Native Addiction Technology Transfer Center. I want to welcome you to our ESAS broadcast today. Today's topic is clinical evaluation and treatment planning. And we have with us speaking today one of our consultants and advisory council members, Avis Garcia. We're happy to have her here with us once again for this December ESAS broadcast. And I want to again welcome everyone. We've got until 1:30 Central, so hopefully we'll have a little time at the end of the broadcast today to take some questions. Jeff and I will be monitoring the chat box as well. And we'll try and circle back to the chat box if you want to post some questions or comments there. We'll try and address those as well at the end. So I just have a few introduction slides that I want to go through, and then I'm going to turn the floor over to Dr. Garcia to go over today's topic. As many of you already know, this event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. We are located at the University of Iowa in the College of Public Health. I am broadcasting to you from the University of Iowa campus this afternoon. We are part of a national HTC network that is made up of 10 regional centers, a national Hispanic and Latino center, and a coordinating office at the University of Missouri. Again, as many of you know, this project is supported by SAMHSA, and it's important to note that the content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the National American Indian Alaska Native HTC. Following the conclusion of today's event, we will reach out to you via email with a follow-up. This follow-up will include a PDF version of today's presentation, and we'll also make available to you a link so that you could share this recorded lecture today with a colleague or a coworker that was not able to join us today. And we will be offering 1.5 NADAC approved CEUs for today's training webinar. So watch for that follow-up email. I will be posting in the chat box a link to a short survey. If you have a chance to complete that survey at the end of today's broadcast, that's great. If not, we'll include the link to that very short survey in the follow-up email as well. The survey is really important to our center and to our funders. It ensures that we're able to continue to provide events like this to all of you. Your participation in the survey is voluntary, of course, but if you would, please take a few minutes to complete this short survey. You can skip any questions that you would like, and I assure you that all of your responses are confidential and cannot be linked to you in any way. If you have any questions about this survey, please reach out to myself or Jeff Ledolder here at our center. We're happy to answer any questions you may have. I know we're gathered here virtually today, but I want to take some time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Baer. Thank you. Well, without further ado, I want to introduce today's speaker, my colleague and friend, Dr. Avis Garcia. Avis is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. She's recently moved to the Montana area, so I'm jealous because Montana is beautiful. And she is a LPC and addictions therapist and holds her doctorate in counselor education and supervision with a specialty in substance use disorder treatment and working with Native populations. Avis has worked with all ages, groups, individuals, couples, and family therapy, and she specializes in treatment of substance use disorders and trauma. We're really privileged and honored to have her with us and part of our consultant team and part of our advisory council. So I don't want to take up any more time. I want to turn the floor over to Avis and let her share with you some really important information about treatment planning. So try and close any other programs you have going on. As I said earlier, you are muted, but we'll try and open the floor up and you can unmute and ask any questions that you may have or comments that you may have regarding today's lecture. I'm going to take my screen down and give Avis a couple of minutes to get her screen up and running. But the floor, Avis, is yours. Thank you so much for being here, and I want to welcome everyone to today's presentation. Looks great, Avis. Thank you so much.
Okay, perfect. I didn't hear you for a second.
I'm sorry, I was muted. I was telling you to unmute, and I was muted. So
I was like, "Can you see my screen?"
It looks fantastic. I'm hoping anyone else want to chime in, but I'm seeing what we need to see. So yeah, Vicky says you're good. So I think we're in great shape. Thank you.
All righty. Thank you guys for taking time out of your busy schedules today to listen to me talk about treatment planning. I have a lot of information to cover today, so I'll try not to go too fast, but in order to cover it all, you might want to grab a pen and paper to jot down some notes so you can ask a few questions at the end. I recently moved to Montana I am now the director of the Crow Recovery Center here on the Crow Agency reservation, and so far I'm really enjoying it. To get started here, the goals and objectives today are to define what treatment planning is, understanding the correlation between assessment and treatment planning, overview of the treatment planning process, looking at the treatment planning history, introduce treatment planning using the MATRS model, and a little discussion on the progress notes. And what is treatment planning? A treatment plan is a result of a collaborative process between the patient and the counselor. The counselor and the patient develop goals and identify strategies and interventions for achieving those. So this is something we work with the client on, and we give them a lot of input into their own treatment plan, asking them, they are the expert on their own lives, and you might want to ask them, what is it you think you would like to work on based on, the assessment results that you share with them. Thoughts on treatment planning. This treatment plan is a living document that can change during the course of a patient's treatment, which means they can either step down as they start to improve, or some of our people struggle a little bit more, and we will sometimes have to move them up a little bit. It's also used for continuing care planning, and discussion should begin with the patient immediately and progress as the treatment process progression post-admission. A patient's recovery plan truly begins the day they complete their primary treatment stay. The more we involve our patients in the treatment planning process, the more meaning and purpose it will have to them. I like to have some sort of form where they know what their treatment goal is that they're working on each week, that they fill out, and they're able to monitor themselves. So they might take a goal that you created together on their treatment plan and put it on their sheet so that they know what they're working on. Treatment plans incorporate information gathered from the assessment, usually the results of an ASI and other instruments. Most of you working for Indian Health Service treatment programs, as I am under a 638 contract, and also the state of Wyoming, requires that an ASI, the Addiction Severity Index, be completed as part of state standards to be considered a qualified assessment. We do a clinical interview. We gather collateral information, such as maybe they're referred from the court, or HR maybe sent them for employment reasons, doctors, other treatment programs, family services, a spiritual advisor, or maybe their significant other is telling them you have a choice of getting help, and looking at what presenting problems that they come with, what brings them to need treatment, because most of the people that I've worked with do not voluntarily walk in the door. They're usually sent by someone. Bridging the assessment with treatment planning is being able to obtain and interpret all relevant information that you received. An integrated treatment plan addresses substance abuse and mental health, illnesses through concurrent treatment. First, you want to address the pressing needs, evaluate the patient's motivation to address substance abuse, identify treatment goals and target behaviors that they want to work on, select interventions for achieving goals, choose measures to monitor outcomes of goal setting, and follow up and modify your treatment plan as necessary. Sometimes something isn't working and we want our patients to have some success. So it might be as easy as having them track their attendance and participation in group. Treatment planning. At a minimum, the treatment plan addresses the identified substance use disorders, as well as issues related to treatment progress, including relationships with their family and significant others, might be their job, their school, spirituality, health concerns, and legal needs. So that has to be made clear up front. To begin with, you want to obtain and interpret all relevant assessment information, looking at the stage of change and readiness for treatment using the Prochaska and DiClemente stages of change. This diagram here on the right-hand side has the pre-contemplation, uh, relapse and recycle, contemplation, preparation, action, and maintenance. And sometimes I would say about half of our people uh, end up having some relapse along the way. The treatment planning process, motivation and motivating factors. Like I said, a lot of people don't come willingly, so they may be harder to motivate than others. The role and importance of patient resources and other barriers to treatment. The impact that the patient and family systems have on treatment decisions and outcomes. Who is supportive? Do they have any supports? And other sources of assessment information. When I worked with people working with the legal system, I often got their pre-sentence investigation through probation, the probation office, and that information was always helpful. As much information as you can get, because some people are not always honest, so they may leave some things out. Explain assessment findings to the patient and significant others involved in the potential treatment. Discuss confidentiality regulations, effective communication styles, what are their preferences, factors affecting their comprehension of the assessment findings, roles and expectations of others potentially involved in treatment. Oftentimes, this is handled through an orientation process where you sit down with them and go over all of this information with them individually or in a group if there's others that are going into a treatment program together so that they all understand where they are. Provide the patient and significant others with clarification and further information as needed, using effective communication styles and methods to elicit feedback. So you also need to remind them that their participation, that this is a team process and it's not just us doing the work. They need to be involved. So they need to participate in groups and counseling sessions. Examine treatment implications in collaboration with the patient and significant others, available treatment modalities, patient placement criteria, the cost issues, the effectiveness of the various treatment models based on current research, implications of various treatment alternatives, including no treatment. I always tell them that I like to start with the lowest level of care possible. And sometimes they might have scored at needing residential treatment, but they're reluctant to go and may give you a whole laundry list of reasons why they can't. And so you can negotiate with them at that point of, this is your treatment and, how can we help you? Are you willing to do this? And so oftentimes some of these people have actually done well in a lower level of care. And sometimes they don't. So then, they were given that opportunity to see if they can do it. So it's every patient is different. No, they're not all the same. And letting them know what's available, different kind of groups that you have, what other things they can do that meets their treatment requirements, understanding their criteria. Most of us in Indian Health Services, the cost issue isn't so important, but oftentimes I like to, when they want to track their attendance, I'll push the button and show them how much it might cost if they were to actually have paid for it, so sometimes they look at it a little differently when you show them that information. You want to confirm the readiness of the patient and significant others to participate in treatment. One of the things I've learned is getting family involved is not always the easiest thing. And if you can at least get them to get one person to be supportive of them, that's helpful to them. Again, this is that motivational process and the stages of change that you need to always be looking at and sharing this with them so that they know where they're at in this process as well. Prioritize patient needs in the order that they will be addressed. Treatment sequencing and the continuum of care. So letting them know, when you come into the program, you attend you're required to attend this program, X number of days, X number of hours. When you complete that, you move on to continuing care. The treatment intensity decreases as they successfully progress through the continuum. Look at their needs. The Maslow's hierarchy of needs. What does this person need? And they can tell you what it is that they think they really need to work on, and the interrelationship among patient needs and problems. Formulate mutually agreed upon measurable treatment outcome statements for each need, levels of patients' motivation, treatment needs of diverse populations. If we're working with our Native people, are they interested and requesting cultural services? Do they have a sweat lodge? What kind of cultural programming do we have to engage them in? How to write measurable outcome statements. Some third-party billers will come in and audit and look at treatment planning and look at notes. So when you're doing your documentation, you have to show how that ties to their treatment plan. So there may be different scores that you'll use to determine how well someone is doing. I use a Likert scale a lot so that the patient can always rate themselves and come up with their own treatment goal of where they want to go. Identify appropriate strategies for each outcome, what intervention strategies will be used, the level of the patient's interest in making specific changes, and treatment issues with diverse populations. Again, the population that you're working with, the criminal justice people, like I said, they really struggle with motivation and interest. But I have seen some improve as well. As many years. I've been in this field for 20 years now. I can't believe it's been that long. But I know what it's like to be new to the field and have a lot to learn. Coordinate treatment activities and community resources. So you need to be very resourceful. And if you're new to your community like I am, I'm learning something every day. Learning who those key people are that I need to be in constant communication with for referral resources. Coordinating treatment activities and community resources with patient needs that is consistent with their diagnosis and placement criteria. What treatment modalities and community resources are available? Where can they go to get a GED, or maybe start looking into college or vocational training? Contributions of other professions and what self-help support groups are available in the community. Current placement criteria and the importance of the patient's racial, ethnic, culture, age, developmental levels, gender, life circumstances, and coordinating resources to that patient's needs. So you want to tailor the services as much as you can to that individual. Develop with the patient a mutually acceptable plan of action and method for monitoring and evaluating their progress. The relationship among problem statements, desired outcomes, and treatment strategies, short and long-term treatment planning. Some people are there with you for a short time. Some people will be with you for a while. So those that are going to be there longer, you might want to set them up for a regular counseling session where you sit down and thoroughly go over their treatment plan with them so that they can see where they're making progress. And again, always being strength-based of pointing out what things they're doing really well and your evaluation methodology. Inform the patient of confidentiality rights, program procedures that safeguard them, and the exceptions imposed by regulations. I know in Wyoming, we had to do a professional disclosure statement. And in that statement, it also tells them, all of your information is confidential, except when there are concerns of you being a danger to yourself or others. We're mandated reporters. So what you share with us based on the information, we have to report certain things. Resources for legal consultation. Is there legal services that are available for people in treatment programming? And the majority of the clients that I've worked with generally meet free legal services based on income and effective communication styles. I'm new to my agency still, and I'm still encountering moms and wives and girlfriends that call and want to make appointments for somebody. So I'm telling them, if you're not the person and they're able and an adult, then they need to call. And, if they sign a release of information to communicate with you, then we can do that. But that they have a right not to share any information if they decide not to. Reassess the treatment plan at regular intervals and/or when indicated by changing circumstances. This is why I said if you have people in IOP programming on a regular basis, it might be a great idea to just have them carry their treatment plan copy with them, or their treatment goals that they're working on, so that they can monitor their own progress. But oftentimes some treatment programs will have them check in once a week or every other week for a one-on-one to review their treatment process, or make it a part of the group where they can discuss that, review and revise it as needed. Sometimes different things come up in life that they need to change, and maybe they successfully completed something already and it's time to add something. On to treatment planning. The more we involve our patients in developing their healing plan, and I often sometimes don't like the word treatment plan, but in the outside world, as I call it, treatment plan is the terminology that's used. The greater meaning and purpose it will hold for them moving forward. So this is what we call person-centered. This is allowing them to be involved in their taking charge of their own treatment planning. Treatment plans are meaningless and time-consuming, ignored, same plan, different names. I would hope not.
It should be meaningful.
Okay. I didn't catch that. We can change that.
Yes.
And some people, some people don't put a lot of emphasis on this. So the treatment plan goals may look very different for a patient at an early level of treatment, and compared to, like I said, depending on how long they're going to be with you in the program, based on the intensity of care that they need, their age, their gender, what substances they're using, their cultural background, any other factors you can think of.
And I think, Avis, this slide is just supposed to represent what oftentimes treatment plans are viewed as. They're viewed as meaningless and time-consuming. They're often ignored, and they're often just cookie cutter, or the same thing for every patient. I think really that's what that slide is referring to. So
okay, thanks
isn't as clear there.
Thanks for correcting me on that.
Yes,
I was like, is this what this is supposed to say? But some people, especially patients that don't want to be there, to them it may be meaningless at that point. I've had people come in just, really angry in the beginning, but after they get to see others that have been there for a while, especially what I love about groups is some people are verbal enough to say, I did the same thing when I got here, but the more you come here, the better things get. So it is an important part of the treatment, and it's very important that they understand that they are in charge of their treatment plan and program and how they progress in the program. Other organizational considerations would be requirements of funding entities and managed care. Is there a duplication of information that is collected? So oftentimes it's a good thing to go through all of the paperwork that you have them complete and look for places where there is duplication, so that you can eliminate some of that and know where specifically you catch this information. So we don't, often I see it all the time when we give them the packet that most treatment centers have of how thick it can be and how much information. Is technology used effectively? More and more companies using electronic health records have portals, and they have the paperwork online that can be filled out online. And so those are really nice as well. Is the paperwork useful in the treatment planning process? So I look for some forms that do go into the treatment plan that we give to the patient that they fill out so that we can use that. The one that I like a lot is called the SNAP, and I like to have them fill that out in their own words. And when we start the treatment planning, that's often a helpful little piece of paper. Field of substance abuse treatment, early work, program-driven plans. This is what he was referring to, Steve was referring to earlier, a one-size-fits-all, cookie-cutter goals, and the agency knows. This is like in the early beginning when we didn't even ask the person what they wanted. It was basically dictated to them. As time went on, the ethics of the whole treatment profession itself took a good look at the work that was being done and decided that, this is probably not a good idea, and we need to change the way things are done. Program-driven plans, patient needs are not as important as the patient is fit into the standard treatment program regimen. This is program-driven. So this is the program saying this is how it's going to be done. Often only includes standard components, little difference among the treatment plans. And like we said, we need to be able to take into consideration the unique aspects of each individual and avoid this as much as possible. Some more on program-driven plans is the patient will abstain from substances, attend meetings, read this, attend sessions. Again, some of this stuff is required, but can be done in an orientation that's not so coming across as program-driven, the things that are expected of them to participate in the treatment day programming. And this 28-day program is old. I don't know if any of you watched the movie 28 Days. It used to be treatment. I've been in programs where we've had people a year, maybe a year and a half, and those were the residential programs. So I've also had people in outpatient programming that had been there over a year and were still struggling, but they still, insisted on being in that level of care. And so we had our moments. Program-driven plans often include only services immediately available in the agency. So it's kind of like, this is all we got. This is what we're going to do. Often don't include referrals to community services such as parenting classes. And that's why it's important to know what community services are available and training your staff on a continuous basis so that they can learn the latest and getting updated treatment information to use with your clients. Treatment planning, here's the paradigm shift. We move to individualized treatment plans with many options that are available, custom style and fit. This is a living document based on the patient feedback in his or her own words. I like to tell my staff all the time, quotes. Everything they say that's very important, even if you're in an individual session, quote that. An individualized plan is developed to match the patient problems and their needs. Like I said, they're the expert on their life. So you can ask them, what can we do to help you? What do you want to change? What would you like to work on? And it doesn't always have to be real specific to that, not using substances. So if they can look at other areas of their life that they want to work on as well. Some of them, it might be, adhering to their medication regimen that they're on. To individualize a plan, what information is needed? Does the counselor need to discuss before? What do you discuss before developing it? Where do you get the information, guidelines, tools used, etc.? There are some good templates and treatment plan guides available. Oftentimes, an experienced therapist will have developed a menu. I guess I could have attached it here, a long list of things that it worked really good with me with adolescents, because I'd be like, well, what do you want to work on? And they'd be like, I don't know. But then when they would see that list, their eyes would kind of open up and they would pick something off of that. Are an adjustable list of goals and action steps based on previous patients with similar issues. Many EHR systems with the treatment center will have a built-in treatment plan program that offers suggestions. And I do know, if you guys are using the AccuCare, the Indian Health Services has most agencies using, the longer you use it and the more information is put in there, it does save a lot of those examples in there that are very helpful. I also like to use the Wiley treatment planners. And I used to have them in books, and now that everything's gone digital, I love the digital use of those. And they're a little pricey, but very helpful, especially if you're new to the profession. I like to recommend that my new counselors use those treatment planners, because those can be helpful. Want to individualize it, what is needed, possible sources of information. Again, your probation reports, they need to make sure they're checking in with their probation officer. They're prepared for those home visits if they have those coming up. Screening results, assessment skills, collateral interviews, examples of individualized treatment plans from previous patients. And sometimes they do like to see examples. So if you can make some that doesn't have anybody's name on it, you could be like, here's an example for you to look at. So I'm one of those, if you show me something, then I get it. So that might be helpful to some people. Some feedback and discussion with your supervisor or mentor about treatment plans. Sometimes I think talking with your colleagues and when you have your staffing meetings is a really good place to talk about those things as well. Looking at the biopsychosocial model. This is key. It is a holistic and responsible way to view patients' needs, strengths, and goals. So when we're talking about the biological, we're looking at what's going on physically, psychologically, and socially. Does the patient have access to a car? Can they access public transportation? How closely do they live to the treatment center? How available are drugs and alcohol in the home? So these are things you have to take into consideration. The ASI problem domains and the biopsychosocial model seem to fit really well together, such as looking at the medical status, the psychiatric status, and the family and social status. Why do we make the effort? So that we can individualize. The treatment plan leads to increased retention rates, which are shown to lead to improved outcomes, empowers the counselor and the patient, and focuses on counseling sessions, provides the patient with an attainable framework to build measurable recovery objectives. Why make the effort? Individualized treatment plans, they fit the patient well. They align with the ASI. The ASI items are used to fit the patient's services to his or her needs. So each area, when you complete the ASI, has a scale on it from 0 to 9. So you're able to score each area yourself when you do their assessment and be like, you could share with them, well, and completing your assessment, you're scoring really high in these few areas, and might be a good starting point. What's included in any treatment plan? We would start with the problem statement, information from the assessment, what's bringing them in. Maybe they had a DUI recently. I'm just saying that because I was in a DUI court program for a long time. So a lot of people were there for that reason. What is their goal statement? What objectives? What will the patient do? And the interventions is what the staff will do. Treatment plan components, Problem statements are based on information gathered during the assessment. Goal statements are based on the problem statements and reasonably achievement in the active treatment phase. Objectives are what the patient will do to meet those goals. And again, the interventions are staff. Other common terms are action steps, measurable activities, treatment strategies, benchmarks, and tasks. Although there are always exceptions, most treatment programs are abstinence-based. Therefore, remaining alcohol and drug-free are often default goals or objectives for patients in early recovery treatment program services. That being said, risk reduction and cutting back on substance use may be possible for patients who are self-referred and do not express an interest in remaining completely abstinent in substance abuse. The risk reduction plans can be effective, but are also wrought with potential risks for patients. I had people, they were just being honest with me. Like I said, court-ordered people that said, as soon as I'm done here, I'm going to go back to doing what I was doing, and then pointing out to them that usually if they're in a court-ordered treatment program, some of them are funded by the state. So, the state is paying for you and the court is paying for you. So, you might as well get something out of this while you're here, and that, I'm not here to tell you what to do, but the program rules are you should remain abstinent while you're participating in the treatment program. Components in the treatment plan, again, the problem statements. We'll skip over that. I think we've covered this a few times already. The discharge plan components are the patient's strengths are reflected. Participants' planning is documented. So we would point out that these are the things that the client has chosen that they want to work on as part of their programming, and that they've done really well in attendance and participation and completing treatment goals in a timely manner. They're motivated. Some considerations in your writing. All problems identified are included regardless of available agency services, such as getting their GED or getting a job. Include all problems, whether deferred or addressed immediately. You can rank them, even pick the top 3. You don't want to have too many goals for them. I like to stick with 2 or 3. Each domain should be reviewed. A referral to outside resources is a valid approach to problem solving. And many small agencies, you don't always have a case manager available to connect them to services. So it may be teaching them how to be their own case manager. They're going to learn how to set up appointments for themselves and contact places for legal services because they want to get custody of their children back or they want to get visitation back. So that could be a part of their treatment planning. Tips on writing problem statements. We want to be non-judgmental. Don't use jargon statements. Don't talk about the patient is in denial or the patient is codependent. This is information that they need to read and they need to see. When we talk about increasing that trust with them, I like to be as transparent as I possibly can. I encourage that of my counselors that work with me. I've had counselors that have been there sometimes longer than me that think we don't share this stuff. And I'm like, no, this is their, it's the patient right to have access to that information, and use complete sentence structure. How we write an objective intervention statement using MATRS. This is an acronym for measurable, attainable, time limited, realistic, and specific. And even though it says MATRS there, I often look at this as SMART. I've seen some goal programs use SMART. But either way, as long as these are all there, we need to be able to measure their progress. Like when you evaluate their treatment plan, maybe they're there with you for 6 months or so, and you're looking at that. You want to know how much progress are they making. Is this something they've already completed, or they're working on it now, or is this something that needs to be changed? Is it realistic? You want to be able to have your patients experience some success so that they're more motivated in their treatment. When we talk about measurable, we're looking at objectives and interventions that are measurable. Achievement is observable, measurable indicators of patient progress, could be assessment scales and scores, the patient's self-report, again, using a Likert scale, behavioral and mental health status changes. Some agencies use other scales. One place I used the daily living skills assessment, and Medicaid requires the DLA to be used, which looks at 20 areas for daily living, and you're able to score that patient and you get a total score. It kind of takes the place of the GAF. So we don't use the GAF anymore, but I like to use the DLA score. And even if they improve by 1 or 2 points, that shows some measurable progress. You want to have the objectives and interventions be attainable. During the active treatment phase, focused on improving their function rather than cure, identify goals, attainable in the level of care provided, revise goals when the patient moves from one level of care to another. So they completed the outpatient programming and now it's time to move on to continuing care or aftercare. So mainly they'll be focusing on relapse prevention in most programs. Time limited. Focus on time limited or short-term goals and objectives. Objectives of interventions can be reviewed within a specific time period. If they're having one-on-one sessions with a counselor or a peer specialist, this would be a good thing to look at their treatment plan regularly to keep them on track. The objectives and interventions need to be realistic. Patient can realistically complete objectives within a specified time period. Goals and objectives are achievable given patient environment, supports, diagnosis, level of functioning, and progress requires patient effort. This isn't something we do for them. This is something that they do for themselves. Specific objectives and interventions are specific and goal-focused. Address in specific behavior terms how level of functioning or functional impairments will improve. The MATRS test, again, measurable, can change be documented? Is it achievable, attainable within the treatment time phase? Time limit is the time frame specified. Will staff be able to review within a specified period of time? Realistic, it is reasonable to expect the patient will be able to take steps on his or her behalf. Is it agreeable to the patient and staff? And specific, do they understand what's expected and how the staff will assist them in reaching those goals? The treatment planning process review, again, the assessment, collecting data and information, identifying problems, prioritizing problems, developing goals to address those problems. Remember the MATRS, objectives to meet goals, interventions to assist the patient in achieving those goals. 5 components of an effective treatment plan. Goals or objectives. Every good treatment plan starts with a clear goal or set of goals. Identify what your patient would like to work on and write it down. Don't be scared of limiting your work. You can always adjust these as time goes on. However, it's helpful to write down and discuss what your patient's purpose is for starting therapy. How will they know when they're on the right path? What will you both use to determine when the patient is ready to terminate? Having a clear goal, make sure everyone is on the same page and that you are both accountable to focusing on what is necessary. Active participation. A treatment plan follows up with how each party will work to achieve the goals. This is really important and often missed. Talk to the patient about your role, how you plan to help them achieve those outcomes. This opens up a great discussion about the role of the therapist and how therapy looks like, specifically when it's compared to others. Oftentimes, I find they come thinking you have all the answers to all their problems, and I explain to them that we're here to help you find the answers to whatever it is that they're struggling with. The other key piece here is how the patient will participate. This is where you have the opportunity to explain what's expected of them and that you're not there to fix anybody. Therapy is hard work. There are some risks involved. And success is 100% dependent on their motivation and willingness to be engaged in the change process. Support, another aspect of treatment planning, is so often forgotten in private practice settings, is the patient support system. It's not just you and the client against the world. They'll need other supports in place to be successful throughout life. Identify any support as part of your treatment plan and have shown your client some of the tools already in their toolbox. It might be good to have them fill out a relapse plan where they have people that they're going to contact. Oftentimes, it might not be their own family that wants to be supportive. Maybe that person is you that they're going to check in with, or maybe that's their probation officer that they built a relationship with, or the case manager that they built a relationship with. So helping them realize that they can do stuff, but the hope is that we can get somebody. Some of them, it's their sponsors. Some people participate in AA and get really good sponsors. Get creative here. Perhaps the client's support is a healthy family member or friend. It could be a pet or a support group. Maybe it's a hobby or spiritual practice that helps keep them grounded. Again, support can be our elders in our community. Some of the characteristic traits like being fiscally responsible, planning ahead, or being very outgoing or creative. These are all supportive things that help the patient to reach their own goals. Outcomes. The last important aspect of the written plan is the outcomes or success. Make sure to write these down at various intervals. Maybe you visit the outcomes once a month, maybe every 3 months. Choose what interval works best for your patient and your style, and make sure to plan and talk about it. Is this still the primary goal, or do we need to adjust something? Are we staying on track with these? If not, is time to redirect, or do we need to revisit some things? What success have we made? You want to make sure you celebrate those successes so that they can feel good about themselves. What will we continue to do in order to reach that goal? Once you do clearly reach that goal, have we discovered other things through the process that we might need to prioritize? It's a time to talk about termination and what will that look like. Client involvement. The most important step to effective treatment planning is it's for last. Involve your patient is crucial. Without their feedback, your treatment plan is no more than meaningful than a term on a paper with a bunch of words on it. So this is their plan that they need to take ownership of. Here is a link to some steps to an effective treatment plan. This is an ongoing conversation that you have throughout treatment. Treatment planning isn't something you do at the first or second session and forget about it. It's an integral part of the counseling process. It's a clinical discussion simply put on paper to provide a clear outline and understanding of the direction you want to go. Documentation. If it's not documented, it never happens. So this is very, very important that we have to do all the time, almost every day, and you should do it. I like, if you have to schedule time in your daily work schedule to get this done. I often encounter staff that let this build up to where they're behind and then they're trying to get caught up. So if you do it right away, you won't have trouble remembering a lot of what you need to document. The documentation includes what session was it, what level of care, the date, their name, the counselor's name, and your signature and credentials. There are several different progress note formats. There is the NAPT, the SOAP. I've never heard of the BURP, but the DAP is probably one of my most favorite. It's very simple and easy to follow. So the NAPT is the narrative, assessment, and the plan and time. The SOAP is the objective, the subjective, the objective, the assessment, and the plan. What are you going to do between now and the next session? And the BURP here is behavior, intervention, the response, and the plan. And that, like I said, is easy. It's the data, the assessment, and the plan. This is the group that we did today. They did very well. They seem to be doing well. The plan is the patient's going to work on X this week as part of their treatment plan. Collaborative documentation is sometimes referred to as concurrent documentation. Is anyone at their agency using this in their practice? This is a process where clinicians and patients collaborate in documentation of the assessment, service planning, and ongoing client practitioner interactions as part of the progress notes. Again, there's another link here for collaborative documentation improvement tips you might want to make note of and check out after this. Given the transition to electronic health records, there really is no better time to consider adding collaborative documentation to your clinical toolbox. Flipping through paper charts is a cumbersome experience, and opening up multiple documents in a workstation is a fragmenting process. The ease of being in an electronic record lends to easy access for viewing progress over time with clients. Collaborating on recording each session and capturing your client's signature from the place you may open doors you had unknowingly walked past before. And I like to tell my staff to take that last 10 minutes of that session that they have with that patient and do the note with them. And I will tell them this is what I'm writing. Oftentimes I'll turn my screen so they can see what I'm writing. I may even let them look at it. How does that look to you? We have the electronic signature pad that they sign on. So then that note is signed right there, right on the spot. That's not always as easy with the group notes, but once they get familiar with the process, they'll know what, we're just documenting their attendance in there. But in my individual sessions, I encourage counselors to get the patient involved in doing that note together. It's just like the treatment plan. Some basic guidelines, again, keeping this information in perspective. Is it measurable, dated, signed, legible, patient's name, or a unique identifier, start and stop time, credentials, attainable, what interventions are used, are you using motivational interviewing, DBT, to address problems, goals and objectives, time limited, are there new problems, goals and objectives, realistic, content of the session and the patient's response, progress towards goals and objectives, specific problems, goals, and objectives addressed. Maybe they need some extra homework, and you can, find them some materials to read, or give them an assignment to work on. Documentation, basic guidelines, entries should be your professional assessment, a continued plan of action. Progress notes may be documented collaboratively. Sometimes I can't say that right. But just like I said, getting them involved in writing that note, I really think that increases the patient's trust in you, knowing that you're sharing that information with them. Basic guidelines, the documentation describes changes in patient status, response to outcome of interventions, their behavior, progress towards goals and completion of objectives. And patients like to know that you're noticing changes in them, even verbally, like, hey, you cut your hair, or I notice you're dressing differently. And they might be like, well, I think one of my clients, I noticed a significant change in the way he was dressing. And when I noticed that, he's like, yeah, that's one of my treatment goals. And so I was really surprised that one of the counselors was, real creative in helping the client and how he presented socially. Summary. Isn't this a beautiful picture? I just love it. Presentation summary. Treatment planning. Obtain and interpret all relevant assessment information. Explain assessment findings to the patient and significant others involved so that they understand why you did everything, what this means to them. Provide the patient and significant others with clarification and further information if they need it. Maybe this person has some trauma, PTSD. Is there some handout material you can give them, or some books you can suggest that they read? YouTube is full of wonderful information, and so I incorporate that a lot and encourage my staff to do the same. Sometimes, you can have them do some research and watch some videos and come back and share that. Examine treatment implications in collaboration with the patient and significant others. Confirm the readiness of the patient and significant others to participate, where their motivation level is. Prioritize patient needs in order they will be addressed. Sometimes they do get someone real involved that wants to be involved in all of that process. And so that's always really good too. I've encountered lately a lot of younger people in treatment that their parents were also had drug and alcohol problems in the past, and they are willingly acknowledge that because they're sober now and they're doing better. So those parents I'm seeing become more involved in their son or daughter or family member's treatment. And so that's something I've been noticing with all my years of being in the program. So that's always nice when the parents are willing to step up and say, I had the same problem and I'm here to help. 7, you want to formulate mutually agreed upon measurable treatment outcomes and statements for each need. Identify appropriate strategies for each outcome. Coordinate treatment activities and community resources with prioritized patient needs in a manner consistent with the patient's diagnosis and existing placement criteria. Develop with the patient a mutually acceptable plan of action and method for monitoring progress. Inform the patient of confidentiality rights, program procedures, and that safeguard them, and the exceptions imposed by regulations. If you're working with a court-ordered treatment program, we oftentimes have to provide regular feedback to that program. Reassess the treatment plan at regular intervals and/or when indicating by changing the circumstances. On to the Asam criteria. This is the levels of care. And those of you that are working in the field, this is the addiction placement patient criteria. The American Society of Addiction Medicine criteria. It's the big purple book. And we're going to go over some of this, and this helps you to determine what level of care the patient needs. It's clinically driven, not program driven. The criteria do not involve the prescribed length of stay, but promote a flexible continuum of care, involve an interdisciplinary approach to care, includes an informed consent, is outcomes driven, and clarifies medical necessity. Some of our people have been engaged in substance use for a long time and may present with some serious medical conditions that needs to be addressed. The Asam levels of care, there is the 0.05, which is oftentimes referred to as early intervention. This could be the form of a relapse prevention class, a DUI, minor in possession class. Maybe some parents, discovered their teenager has been engaging in substance use and they just want them to get some help. Level 1 outpatient is usually less than 9 hours a week. Level 2 outpatient is anywhere from 9 to 19 hours a week. And I've learned moving to Montana from Wyoming. And then when I was last in Wyoming, I was in Cheyenne and I was close to the Colorado border. And I thought we had some high standards, but Colorado's requirements for these levels of care were much higher than Wyoming's. And then I'm noticing Montana's is much less. So, but they haven't really set a specific amount. So this is just something to keep in mind when you're looking at those levels of care that are being recommended. The level 2 is intensive outpatient programming is anywhere from 9 to 19 hours a week. Like I said, in Wyoming, the hours were 9 a week, and Colorado had them doing 12. And then level 2-5 could be partial hospitalization. This is 20 or more hours a week. This may include some medical treatment. Level 3 is your residential care. You know, they may be in such bad shape, you need to totally remove them from their environment and get them stabilized where they have 24/7 supervision. And level 4 is your medically managed inpatient services. And this is where we have people, I said, with the very serious medical complications, and oftentimes that's cirrhosis. The Asam assessment, reassessment, and discharge. So you're looking at this all the time, just like the treatment plan. We're looking at, is this person in the right level of care? So the Asam dimensions that are looked at include, there's 1, 2, 3, 4, 5, 6. But if you break them down, they hit under these main categories of physical. So the physical aspects will look at acute intoxication and withdrawal potential. The biomedical conditions, what health problems do they have, if any? The second area would be the emotional and cognitive. That would be emotional and behavioral conditions. And treatment acceptance and resistance, also known as their readiness to change level. Where are they? Behavioral, what is their relapse or continued use potential? Are they able to do well being at home or in their regular environment? And what does their social environment look like? Again, these are the areas that the dimensions cover: intoxication, withdrawal, biomedical, emotional, behavioral, cognitive complications, their readiness, relapse, continued use, continued problem potential, and their recovery living environment. Some people live in an environment where their home is really safe. They, nobody drinks there, nobody uses any substances, but then there's those people that we send home to somebody else in the home is using substances, and that's one of the barriers that they're up against. So the severity in each dimension can be rated as mild, moderate, or severe. And then further we go, we'll show you that there's a scoring process to this as well. The levels of care, the early intervention, like I said, this is can be one-on-one counseling, educational programs such as the DUI class, relapse prevention. I have had some people, when we try to meet people's needs where they are, some people are working and we can't, get them to certain classes at certain times. It's not always preferable, but sometimes we do need to do what we can to help the people. Patients don't meet criteria for substance-related disorder. So like I said, this might be, first time they ever got a DUI in their life, not something normal. Problems and dimensions 1, 2, or 3 are stable, or they're being addressed. So they're not having any mental health problems. They're not having any physical problems. Level 1 therapies include individual and group counseling, motivational enhancement, opioid substitution, family therapy, education groups, occupational and recreational therapy, psychotherapy, other therapies, continuing care, and post-primary. This is your post-primary treatment. So this is what we would call stepping down out of level 2. And for some people, getting out of residential, stepping down would be coming sometimes to an outpatient program. Level 1, outpatient treatment. Dimension and admission criteria in dimension 1. For example, the person would not have any signs or symptoms of withdrawal. They've been sober for a while now. They haven't been using any substances. Dimension 2, biomedical conditions or concerns are stable. They see a doctor for whatever medical condition they might have. In dimension 3, A, B, A or B, and C and D. So here's the A, B, C, and D. No co-occurring mental disorder symptoms, or their symptoms are mild or stable. Psychiatric symptoms are mild, but mental health monitoring is needed. So maybe they are seeing someone for that issue. Mental status doesn't interfere with understanding or participation, and they're not a danger to anyone else or themselves. Level 1 outpatient dimensional criteria in dimension 4, A and B or C or D. They have a willingness to comply with treatment. They acknowledge substance use and want help. Are they ambivalent about substance use or don't recognize substance use? Dimension 5, able to achieve or maintain abstinence only with support. Dimension 6, A or B or C. So any one of these. They have a supportive environment, or is there an inadequate system, but they're willing to obtain support. Family is supportive, but needs intervention to improve chances of success. So maybe they need a little bit of family therapy. Level 2-1, intensive outpatient admission criteria. Dimension 1 would be no signs or symptoms of withdrawal. Biomedical conditions are monitored. Stable, or they will not interfere. Dimension 3 could be A or B, abuse of family, diagnosed emotional, behavioral, or cognitive disorder that requires monitoring. Dimension 4, A or B, so either one of these, they have a need for structure, need for repeated structured intervention, so coming to classes, however many days a week for however many hours a week. Dimension 5, symptoms are intensifying and then deteriorating at a lower level of care. Dimension 6, A or B, current environment makes recovery unlikely. Current social situation is not helping recovery. Level 3-5, we're going up into the residential criteria. This is admission for residential. Dimension 1, minimal or severe withdrawal, or severe but manageable in detox. Dimension 2, none are stable. Receiving concurrent medical monitoring requires medical monitoring, but it's manageable. So some residences have access to physician care or have nurses on staff. Dimension 3, A or B, is their repeated inability to control impulses. Personality disorder requires high structure to shape behavior. Dimension 4 can be A or B, marked difficulty with or in opposition to treatment. Dangerous consequences if not engaged in treatment. And these could be our real serious people that do not even think they have a problem because they've been doing it so long, and the environment that they're in is real similar to people using at that same level. Dimension 5, like I said, they don't have no recognition of skills needed to prevent continued use with dangerous consequences. Dimension 6, A or B, their environment is dangerous. We need to get them out of there. Patient lacks skills to cope outside of a highly structured 24-hour setting. You know, like I said, everybody comes in differently that needs help. The withdrawal management overview, components of withdrawal management services at all levels, 1, 2, 3, 2, 3, 7, and 4 in Asam, are provided as part of a continuum of withdrawal levels in the Asam. So again, if you have the Asam book itself, you could take a good look at that section and see what that includes. Withdrawal management criteria includes a continuum of care that ensures the patients can enter substance use disorder treatment at a level appropriate to their needs and step up or step down to a different intensity of treatment levels. Withdrawal management continued at intake. The process of admitting a patient into substance use disorder treatment program includes a substance use evaluation, the diagnosis of the substance use disorder, assessment of treatment needs, which includes the physical examination and/or laboratory testing, observation, the process of monitoring the patient's course of withdrawal as frequently as deemed medically appropriate, may include but not limited to observation of the patient's health status, medication services, the prescription or administration related to the substance use disorder treatment services and/or the assessment of the side effects and results of the medication. Discharge services, preparing the patient for referral into another level of care post-treatment, return or re-entry into the community and/or the linkage to the individual to community treatment, housing, and human services. The withdrawal management continued, licensing and certification requirements. Different places have different criteria for managing that. I've worked in a detox center right out of my master's program as part of my internship. And they always had, that program always had a nurse, a registered nurse on staff, like at all times. And we had people that were maybe bachelor degree level, and they called them psych techs, but they were given the training to administer, they called it the CEWA, that is the withdrawal assessment form. We took their vitals every hour to, mainly to check their blood alcohol level was what was my experience was. But it's to provide them with withdrawal management and detoxification services. Oftentimes, you know, we were suggesting that they look into treatment and being able to connect them with treatment. Here is the ASAM risk rating and level of care. And when you look at this at first, it might be a little confusing because what this is, the risk rating guidelines are as follows. And I'm going to switch to a scale here that will be more helpful, a chart. So there is a risk rating of 0 to 1. So it's anywhere from 0 to 4. So 0 to 1 would be the level 1 continuing care. Risk rating of 1 to 2 would be equivalent to level 1. A risk rating of 2 to 3 would be a level 2-1, and a risk rating of 3-4 A or B would be 3.5 residential.
We'll, and Avis, I think we'll probably add a slide. I didn't see a slide that, okay, here we go.
I added this.
Oh, great. Okay.
This is what I made the most sense to me when I was first starting out, and I found it to be really helpful as I've become a supervisor of counselors or training counselors of using this form here. And this gives you all the levels of care across the top of the form. All of the dimensions are listed here. And so when we say 0 to 4, this is 0, 1, 2, 3, 4. So this is the alcohol intoxication or withdrawal potential from whatever substance. So if they were a 0, that would be they're not having any withdrawal risk. If they were a 1, this means they're physiologically dependent on opiates or requires medication treatment to prevent withdrawal. And this one here would be, this is 1, 2, 3, 4. So this is a crosswalk. That's what this is called, is the crosswalk. And so the level 1, if you look at every dimension, it's like the first 3, there's basically 1 through 3 doesn't affect them at all, or they're very stable. And then the dimensions 4, 5, and 6, this is the willingness to treatment acceptance. 0, they're willing to participate. And then as you see, the more it goes, that their poor engagement, as you can see, the 4 would be here. So this is how you would rate them from 0, 1, 2, 3, 4 in each rating. And oftentimes I would just put a circle around these, and kind of as a guideline would be like, hey, if we've got 3, at least 3 for that level of care, we're probably leaning towards that level of care for that individual. And down here is where the clinician signs. Here is where you can put a check mark on the level of care. This is kind of like a supporting documentation or justifying why you're recommending that level of care. And then there's a few questions at the bottom of this one. I've attached this as a handout so you can print it out and start using it if you want, especially if you're new to the field. I find this very helpful, and I have staff. This has been real helpful to them. They were glad when I gave this to them. So I like to share it. And it's kind of hard to read the fine print on the screen right now, but once you have the actual document in your hand, it'll make a lot more sense to you. Okay, it looks like we've reached the end of all of the slides that we had to cover today. Thank you, everyone, for taking time to attend this webinar. There's my contact information if you ever have any questions you want to ask. We are open to requests to present special topics or future presentations. We do travel to provide live in-person exam prep classes. And I covered a lot of material today. And as I was giving feedback to Stephen before we got started, I told him, I said, there's like so much material here. This could be like 3 1.5-hour presentations. So if you wanted to request that, I'm open to that. And if there's something, like I said, there's something you're interested in that's specific to substance abuse or mental health, I'm open to special requests. I do research for the presentations that I give. And again, your being here lets me know you're interested in building your skill set to help the people that you're working with. And we'll open up for comments and feedback.
Feel free to unmute if you have some questions. And I do have some supplemental ASAM handouts too, if you're interested, just to help explain the risk ratings a little bit better. I know it's confusing if you're not utilizing this additional assessment, but it does tie in nicely to treatment planning. And as some of you know, we use the ASAM as a guideline and as a supplement to our primary assessment tool. So it's a great way to support and back up your recommendations for level of care and your continued stay reviews for patients that are progressing or struggling in their current level of care. How many of you are using Acm Criterion in your practice? You can use your hand raising feature if you want. Any chance you get to use a hand raising feature or a thumbs up maybe? There we go. Dee Dee says yes, Heather says yes. So this may be new material to many of you, and it's a lot. It's the Acm Criterion really is developed by Dr. Mealy, and it's been around for many years, and it's been refined in the last, I'd say, a decade to really be and emphasize rather than program-driven guidelines. It's really based on patient-driven progress. So it's a really nice supplement to whatever primary assessment tool you're using. We're getting some thank yous coming in on the chat board. I am going to post the link to our survey again. If you would like to do that now, you don't have to. We'll give you another opportunity to complete this 5-minute survey when we follow up with you individually. Any questions? You can feel free to unmute if you have any questions for Avis or anyone on the call here. Well, again, I want to just thank, of course, Avis Garcia for going over a lot of information. And we look at that, we're right at the bottom of the hour. So this is incredible. We will do this again in a month's time. We like to do these the first Wednesday of every month. So we'll broadcast again in January, and we'll have another topic that's related to the core functions of substance abuse counseling. So until then, please, everyone, stay safe, stay healthy, and stay connected. And we'll see you again soon. Thank you, everybody.